Welcome to our second video on diseases of the esophagus. Let's begin. In this lecture, we will discuss diffuse esophageal spasm, esophageal hiatal hernias, and Mallory-Weiss syndrome. We'll discuss definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management of diffuse esophageal spasm. Diffuse esophageal spasm represents the uncoordinated esophageal contractions of normal intensity. Risk factors for diffuse esophageal spasm include gastroesophageal reflux disease and very hot or cold liquids. Esophageal acid reflux in GERD is proposed to stimulate uncoordinated esophageal contractions. Very hot or cold liquids can also induce esophageal contractions. Although the exact mechanism is unknown, the mitral valve prolapse and anxiety are also implicated in the development of diffuse esophageal spasm. Diffuse esophageal spasm is caused by some sort of irritant stimulus which activates the myenteric plexus. Activation of myenteric plexus stimulates non-peristaltic, uncoordinated esophageal contractions. Let's talk about clinical features. Diffuse esophageal spasm is characterized by dysphagia to both solids and liquids due to impaired esophageal peristalsis. It also presents with retrosternal chest pain similar to angina. However, in contrast to angina, the retrosternal pain due to diffuse esophageal spasm is non-exertional. In other words, it's not worsened by physical exertion. Additionally, retrosternal pain due to diffuse esophageal spasm is exacerbated by certain foods and beverages. On the other hand, angina usually has no association with ingestion of foods or beverages. Let's move on to diagnosis. Barium swallow during attacks will show corkscrew esophagus due to simultaneous contractions at multiple different sites along the esophagus. Esophageal manometry is the gold standard test for diagnosis of diffuse esophageal spasm. It typically shows uncoordinated contractions of normal intensity and amplitude. ECG and troponins are usually ordered to rule out cardiac causes of retrosternal chest pain. Here we see the barium swallow image of a patient with diffuse esophageal spasm. We can appreciate the corkscrew appearance due to simultaneous contractions at multiple different sites along the esophagus. This image compares the esophageal manometry findings between the healthy patients and the ones with diffuse esophageal spasm. We can see that there are multiple simultaneous contractions of normal intensity at multiple different sites along the esophagus. Management of diffuse esophageal spasm includes relaxation of esophageal smooth muscle by calcium channel blockers or nitrates. A 55-year-old obese woman presents to the physician reporting occasional retrosternal chest pain radiating to the left arm and jaw. Chest pain is not exacerbated by exercise or stress, and it is not relieved by rest. She experiences pain after she drinks hot coffee. ECG is normal, and test for serum troponin 1 is negative. Barium swallow during the painful attack shows wavy esophageal contour. Which two classes of medications can be used in the treatment of this patient's condition? This patient has retrosternal chest pain radiating to the left arm and jaw. Chest pain is not exacerbated by exercise or stress and not relieved by rest. ECG is normal, and test for serum troponin 1 is negative. These findings make the cardiac chest pain less likely. Given that the patient experiences pain after she drinks hot coffee, the most likely diagnosis is diffuse esophageal spasm. Diffuse esophageal spasm is evidenced by wavy esophageal contour on barium studies during the painful attack. Diffuse esophageal spasm is treated with either dihydropyridine, calcium channel blockers, or nitrates. We'll now move on to esophageal hiatal hernias. We will discuss the definition, causes, pathophysiology, clinical presentation, diagnosis, and management of esophageal hiatal hernias. There are two types of hiatal hernias, sliding and paraesophageal. Sliding hiatal hernia is the most common type, and it is the herniation of gastric cardia and the gastroesophageal junction through the esophageal hiatus of the diaphragm. Paraesophageal hiatal hernia, on the other hand, is the herniation of gastric fundus through the esophageal hiatus. Importantly, gastroesophageal junction remains below the diaphragm in case of paraesophageal hiatal hernia. Here you see the illustration of the two different types of hiatal hernias. Before we describe each of these hernias, I'd like to point out the phrenoesophageal membrane. This is because abnormalities of the phrenoesophageal membrane predispose to hiatal hernias. As we already mentioned previously, sliding hiatal hernia is caused by gastric cardia sliding through the esophageal hiatus. Sliding hiatal hernia is sometimes referred to as hourglass hernia because it looks like an hourglass. Paraesophageal hiatal hernia, on the other hand, is due to herniation of gastric fundus through the esophageal hiatus. Let's talk about causes. Sliding hiatal hernia is due to excessive laxity of the phrenoesophageal membrane. Excessive laxity of the membrane, in turn, can be induced by obesity, advanced age, and increased intra-abdominal pressure. On the other hand, the paraesophageal hiatal hernia is caused by a defect or focal weakness in the phrenoesophageal membrane. Let's move on to clinical features. Hiatal hernias, especially the sliding hernia, may be asymptomatic. When the hiatal hernias are symptomatic, they mainly present with the symptoms of gastroesophageal reflux disease like heartburn, chest pain, and regurgitation of food from the stomach. Halitosis may also be present. Diagnosis of hiatal hernias can be established with the barium swallow and endoscopy. Sliding hiatal hernia will exhibit hourglass appearance on the barium swallow, while paraesophageal hernia will show gastric fundus next to esophagus. Endoscopy will reveal upward displacement of Z-line in case of sliding hiatal hernia. Z-line is the junction between pink esophageal and red gastric mucosal layers. However, endoscopy in paraesophageal hernia will show normal position of Z-line. Here we see the barium swallow image of a patient with sliding hiatal hernia. We can appreciate the hourglass appearance of the sliding hiatal hernia due to the herniation of the gastric fundus. This is the barium swallow image of a patient with paraesophageal hiatal hernia. We can see the herniated gastric fundus. This is the endoscopic image of a patient with sliding hiatal hernia. We can appreciate the upward displacement of the gastroesophageal junction, also known as the Z-line. Upper pink mucosa is the normal esophageal mucosa, while the lower red mucosa is the normal gastric mucosa. Management of the hiatal hernia starts with lifestyle modifications like weight loss. The patient should also avoid spicy food, cigarettes, coffee, because these can exacerbate the symptoms of GERD. Pharmacologic management includes proton pump inhibitors. Surgical management, on the other hand, includes the surgical fixation of gastric cardia, or fundus, below the diaphragm. A 58-year-old obese man presents to the office with occasional retrosternal chest pain, heartburn, and sour taste in his mouth. Barium studies reveal herniation of gastric cardia through the esophageal hiatus of the diaphragm. What is the most likely pathophysiology of this patient's condition? This patient presents with occasional retrosternal chest pain, heartburn, and sour taste in mouth. Barium studies reveal herniation of gastric cardia through the esophageal hiatus of the diaphragm. These findings are consistent with the diagnosis of sliding hiatal hernia. As we already explained in the previous slides, the sliding hiatal hernia is caused by phrenoesophageal membrane laxity. Let's move on to Mallory-Weiss syndrome. We will discuss definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management of Mallory-Weiss syndrome. Mallory-Weiss syndrome represents the longitudinal lacerations of mucosa at the gastroesophageal junction. Let's talk about risk factors. Severe retching and vomiting predispose to the Mallory-Weiss syndrome. Conditions characterized by frequent, forceful vomiting can be complicated by Mallory-Weiss syndrome. These conditions include alcohol use disorder and bulimia nervosa. Let's briefly review pathophysiology. Forceful vomiting increases pressure in the stomach. Increased pressure is then transmitted to the gastroesophageal junction, which mechanically induces longitudinal lacerations of esophageal mucosa. Mallory-Weiss syndrome presents with hematemesis, which is bloody vomitus. This is due to mucosal bleeding from the laceration. Epigastric pain may also occur because gastroesophageal junction is located in the epigastric region. Radiation of pain to the back is also possible. Mallory-Weiss syndrome is typically characterized by insignificant mucosal bleeding and normal vital signs. This is in contrast to the presentation of esophageal variceal bleeding in cirrhotic patients. Variceal bleeding is profuse, accompanied by severe hematemesis and signs of hypovolemic shock like hypotension and tachycardia. Diagnosis of Mallory-Weiss syndrome is based on the combination of clinical presentation and endoscopy finding. The classic presentation is hematemesis and epigastric pain after vomiting. Endoscopy, on the other hand, will reveal longitudinal lacerations at the gastroesophageal junction. This is how Mallory-Weiss syndrome looks like on endoscopy. Please note these longitudinal lacerations at the gastroesophageal junction. The patient suspected of having Mallory-Weiss syndrome should be temporarily placed on nil per os regimen. In other words, they should not take anything orally until the bleeding stops. Intravenous fluid resuscitation may become necessary in case of severe volume depletion due to vomiting. Proton pump inhibitors are also administered to reduce exacerbation of bleeding by acid reflux in the distal esophagus. Bleeding will stop spontaneously in most cases of Mallory-Weiss syndrome. However, if bleeding does not stop, we could perform the esophagogastroduodenoscopy with cauterization of mucosal laceration. This is when the physician cauterizes the bleeding site by applying heat to the mucosal wound. A 28-year-old woman presents to the emergency department with retrosternal chest pain and hematemesis. She has bulimia nervosa and she was trying to vomit everything that she ate at the party 2 hours ago. Her vital signs are normal. Endoscopy is performed. What is most likely to be seen on endoscopy? This patient with bulimia nervosa was trying to vomit everything she ate at the party 2 hours ago. Now she presents with retrosternal chest pain, hematemesis, and normal vital signs. This presentation is consistent with Mallory-Weiss syndrome. Endoscopy in case of Mallory-Weiss syndrome will show longitudinal lacerations at the gastroesophageal junction, and that concludes the section.